and Dr. Armagan. Put this aside. So the acronyms we're going to clarify very quickly, but I just want to ask everybody if anybody had heard about ERAS. Are you familiar with the term ERAS? Yes? Are you familiar with the term EPOC? No? So that is good that I'm here. I'll let you know what these are. So these are, we're going to go more in depth, but these are the programs that I just want you to give attention to as we go along. There will be some interchange between ERAS and EPOC. I will take your attention to this. So today we're going to talk about the need for transformational care, and then we're going to critique the ERAS pathway implementation strategies, and evaluate our program at Harborview called EPOC, and look at their outcomes. I have no disclosures to make. We are having a huge change in healthcare systems. Industry is never seen this sort of change before. There's a lot of mergers going on, a lot of developments, and we're trying to catch up. And as we catch up from fee-for-service type of payment to pay-for-value, this equation becomes an important one. I like this version. There are several versions of it, but this is the appropriateness, outcomes, satisfaction divided by cost. So these are the things that we're trying to address in the contemporary healthcare now. This just come out this year. There's a great interest about U.S. healthcare expenditure and outcomes. This is the latest paper on this. And again, we remain champion of healthcare spending in the whole world. The dotted lines talks about the mean of each segment. Government spending remains below the mean of this country's aggregate, whereas the private spending took itself off the chart. So there are a lot of money going for private care delivery. To accompany this paper, Ezekiel Emanuel, I don't know if you heard him, he's one of the authorities in healthcare cost and modernizing the care delivery. So he did an editorial on this article, and he identified from the data that was presented what are the four most biggest expenses in healthcare. So drug prices are on the top. High margin, high volume cases follows that. We are doing many of those cases. They are more expensive than anywhere else in the world. So they're costing a huge amount of money to the U.S. healthcare and us as public. Their administrative costs about 8% being calculated in 2016 data this is. And a lot of imaging that is happening unnecessarily and very expensive imaging happening. So this is his book that talks about the reinventing American healthcare. But most importantly, his recommendations are important, I think, to just briefly understand. It talks about surgeons and proceduralists should prove that patients are engaged with the shared decision making using the aids that is provided, and the performance data is a requirement for being paid for the procedure. And then the second recommendation is the final price should be modified based on the objective quality metrics, such as rate of surgical site infections or other complications. So this is coming, and we know this is coming. This is becoming more sort of common talk in the healthcare arena. There are two nice websites if you like to go to Commonwealth Fund website to look at national cost on quality. And also Peterson and Kaiser, they recently joined each other to produce a quality dashboards for healthcare systems. So these are very nice websites, very nice interactive data you can create and look at with their collection. Locally, Washington State has been doing the BRIE collaborative. This foundation of BRIE collaborative was established to reduce the imaging cost and numbers in the Washington State. Now has expanded with many programs. Foundation for Healthcare Quality is a non-profit organization, Washington State, that collects hospital data. Spine program is one of those programs they collect data for, and I'm the medical director for the Spine Club since 2016, June 2016. So if you have further questions on that, I'm happy to answer later on. But what we do with the foundation work is collect hospital spine surgeries. These are 5 levels and below, and then distribute that information back to hospitals to see how they compare to the other hospitals in Washington State. We are in the accountable care network, so we need to show results. We need to show systematic approach to our patient care, show patient satisfaction, outcomes, and appropriateness. And BRIE, when BRIE is revising the recent recommendations for the spine work, and those recommendations usually adopted by our ACN partners, and they expect to see the same thing. So the revision is almost complete for public viewing shortly, and it will come to the neurosurgeon and orthopedic associations in the local associations to have a look at them and make a recommendation and give your opinions. Please look out for those. And of course, neurosurgery and orthopedic surgery are included in this ACN, and spine is a really important area for our ACN partners and what we deliver to them. So knowing all that, why I'm going to talk to you about ERAS, it creates some sort of urgency. We need to reduce the unnecessary variation and create standardization of care delivery. And this was actually started, the first seeds of this was started in 1997, right? So it's almost 20 years ago in Denmark by the surgeon, colorectal surgeon called Henrik Kallet. He discovered that his patients was having a lot of fluid and bowel mucosa was swelling up and then causing a lot of leaks, anastomotic leaks. And they were sitting in the bed, lying down for days to come, and that was causing a lot of discomfort to the patient, and outcomes was not good. And he said, I'm going to do fast-track surgery. And these was like, 7 items that he said, I'm going to standardize and work with my team to make sure pain is managed well and stress response is addressed, nausea, vomiting, all those sort of dealt with. After that, sometime later, I was just back in UK, starting my consultant work. We've been told that there's no money left in the bank accounts of NHS to pay physicians there. Wow. Because Nottingham University Hospital was borrowing money from the bank to pay their monthly salaries. We were like that. And that was, almost bankrupted. It actually is bankrupted. And they said, why don't we find the variation, if there's variation in the care delivery, and address them with a set of criteria. Let's call them ERAS, from the fast track to ERAS. And Monty Myton, dear friend, so he come about and said, I can lead this, and NHS, Department of Health gave them the opportunity, and they created a team, and they made some guidelines for the NHS to deliver surgical care around the enhanced recovery programs at that time. So we're coming towards the recent times, and America is catching up with the developments happening in the world with the ERAS initiatives. And Dr. Pellegrini asked Vinnie Plarisetti, who is the general surgeon, and me to spread the ERAS across the surgical specialties. And these were his sort of quotes. We should have the engaged clinicians to deliver value, aligned with our mission to improve health of the public and practice evidence-based medicine, which we do, but eliminate the non-vital parts and redundant variables from the system, if possible. It is not about doing more for less, but it's about removing barriers to do the right things easier. So what is ERAS? So ERAS is like, probably you heard about sepsis care bundle, right? So there's certain things you need to do, the diagnosis and the treatment. So this is about doing this 22 elements in the preoperative phase, intraoperative phase, and postoperative phase. Things such as patient education and shared decision making, medical optimization assessment, nutrition for carbohydrate loading in the pre-op area, and intraoperatively, we're already doing an antibiotic prophylaxis, thromboprophylaxis, nausea, vomiting prophylaxis. Try to aim not to put any drains so patient gets mobilized earlier. It's not very relevant to spine, but for colorectal patients, it's a big deal. Avoid the fluid overload. Do zero balance. It's not keeping the patient dry or give too much. Do a goal-directed fluid management and zero balance. The term being used in the modern sort of resuscitation and fluid maintenance these days, and a maintenance of temperature. And post-operatively, again, early mobilization, eating, feeding, getting the patient out of the bed. We do many of these, but there are a lot of variations in our patients in the hospital. Not everybody religiously sort of follow these things. So that is where ERAS type of work will help to standardize the care. If you look at any one of these care items, individually they don't make much difference to outcomes. So people studying the nutrition, for example, or pain management may not see it by itself improves the outcome. This sort of standards based on the marginal gains theory. You do a little bit each time, every day, for everybody, and gradually you see sudden inflection point, things get better. Or if you don't do the things for a period of time, you suddenly need to create a fit program to rescue your health system. So I think this is one of the tools we can use to improve care delivery and reduce cost as we go along to help with our financial resuscitation. Is there any evidence? Is there any publication? Not really for the spine population. Wainwright published this in 2016, a review article. Most of the information for ERAS comes from the colorectal population or orthopedic joint replacement population. So, but they're adaptable probably to spine population because they, at least the joint, somewhat a little bit similar. After that paper, Miami Jackson Memorial published this ERAS program for the lumbar spinal fusion procedures, which is actually the microdiscs. You know, they're minimally invasive surgeries. And then the protocol being published just recently from the group from the University of Pennsylvania, they're going to do a prospective trial, which will be the really gold standard probably if they achieve that. So they are sort of starting this sort of patient collection now. So how do you implement ERAS? That is the question. And it's not easy. There's a lot of people involved to do the ERAS well. And this is where the EPOC program comes in. So EPOC program for Harborview, called the EPOC stands for Enhanced Perioperative Care Program. And it is not just that care delivery, but it encompasses all the education needs to be done, all the administrative work needs to be done, and the data needs to be collected, and your teams to get together to discuss how the care delivery should take place, nurses, physiotherapists, nutritionists, transfusion services, they all need to come to the table to contribute their portion to create accountability. So people in the team who says this needs to be the norm for this type of surgery and agrees, they need to have accountability to deliver that. So that makes this program stick around and have a longevity. So what does EPOC program aims for? Care coordination, which has been a problem, a long time problem until recently, still trying to work out issues. Cost control, outcome improvement, patient and staff satisfaction, evidence-based standards, and data to help to make us to see how we're doing. And it starts way before patient becomes a surgical candidate, all the way to the post-discharge arrangements. What we did with the EPOC program in 2013, we created spine ERAS, and intraoperatively we started doing this components I showed you, multimodal analgesia, fluid management, nutrition, and so on. The success of the program led to develop sort of recognition by the administration, and they said, this is good, let's, they start giving some percentage of my FTE. Why don't we make this a bit bigger and spread it to other specialties? And then to do that, we wanted to show data so that prove that it works. So we started to develop the database, working with the QI and IT teams. And the ERAS then transformed into EPOC program in 2015. And then 2016 now started to spread to other specialties other than spine. So spine was the first one to start with. And now we're doing it for general surgery, vascular, urology, and surgical site flaps for Harborview. This year our aim is to further develop the concept of integrated pre-op clinics and also work on the surgical multidisciplinary board for the complex spine patients who needs critical decisions to whether to have surgery or no surgery. If there is no surgery, what to do with that patient going along with the geriatrics or palliative care. So we had our first meeting last month, inaugural meeting, and then we will follow that, and our surgical colleagues are all invited. So the tools we use, we do the PDSA cycles. We take individual items like nutrition I mentioned, and then try that in a group of patients, and then test the results, and then make the plan and implement, and then we refine it if there is some problems, how to give the carbohydrate loading, where to give it, is it costly, and then go over again, do the 360 PDSA cycles. This is one of the recent things we are tackling as it is becoming more important, that shared decision making, is, we used to do paternalistic information to our patients. We used to say, this is the red pill, you need to take this, it will be good for you. And then we moved to informed medical decision making, right? Remember what we said? Then we said, this is the red pill, this is the blue pill, which one would you like to take? Right? And then, now the shared decision making, that involves asking the patient, what is your most important priority? Get them involved on the decision with judging their values and preferences, so we can together agree on what we're going to do for going forward. So this becomes important. It becomes so important, the tools are sort of generated. Washington State Healthcare Authority just put out patient decision aids for spine surgery. So you will be hearing soon about how to implement these. These are the information about them on the website, so you can have a look. We were waiting for this for a couple of years. It's finally come out. So we have patient-friendly care maps. to get the patient engaged in the process. They know what to expect in the day before surgery and surgery day. So these took long time to develop, and then there are multiple languages that are available in the ORCA as well as in the EPIC, so it can be printed out. You're already giving these to your patients. We want to have standardized order sets to measure variation, and this is where your inpatient spine surgery order sets sits. So if you put the spine on the search box, you will see the major spine pathway. So all your elective spines coming in should receive this sort of order set. So there's still a lot of variability what order set we are using. I'll show you a bit more about this. So this is how the order set looks like. It's a multi-stage order set. It has general care orders. So if the patient is going to floor, you're just going to put the general care, and acute care orders. If they're going to ICU, ICU will put those orders. But you will be able to see what the ICU ordered for this patient when the patient becomes floor patient. So that creates the continuity. You would know what was the care in the ICU. And you see there are a couple of references here, checklists and care, patient-friendly care maps, so you can reference those as well. So implementation tools, we worked hard to look at the questionnaires the patients are receiving. There was anesthesia clinic gave a questionnaire for patient to fill. Surgical clinic gave 6 pages of document for them to fill. Medicine operative consult clinic gave 2 pages. That was overwhelming for the patient. And then we condensed all these. I don't know whether neurosurgery clinic has this running right now, but there's a 3-page questionnaire that answers and satisfies all these clinics. And along that, we did templates, checklists, and a lot of education to help to deliver this program. And this was the traditional care in the pre-op setting. So your patients on the dotted boxes, you guys are represented with S, your clinics are there, and then after seeing and deciding you want to operate on this patient, you either ask a couple of medicine or the PAC to consult, or APS, and then book the patient for surgery. And the time, at the bottom you see the timeline. Time was very short to do anything about these patients. So this integrated clinic approach we're hoping to achieve in long term is to have surgical clinic together with the APS and physiatry and PAC and MOC, seeing the patient together in one location, rather than patients traveling around the hospital from floor to floor, and using the most sort of lean approach to that care, giving the right information without any sort of duplications, and then have that opportunity early enough so we can actually do the referrals that is necessary to optimize the patient care. So we don't care for the diabetes complication while the patient had the surgery in the hospital. We care for it before so they don't get a complication. Because we're going to be dinged for the complications. We're not going to be paid. We're going to be penalized. We can't afford to have them having wound infections after the surgery. So they need to come in the best state. So this is the graph to show you roundabout where we are from surgery appointment to admit dates. So these are about 20, 15, 19, 25 patients. There's about 12 to 8 days variation. And there's a couple of outliers to those. Days on the y-axis. We want at least 2 weeks to work on these patients if possible. And have the flexibility, if the patient is not ready, be able to postpone this patient and get them optimized. We do some carb loading, and we revise our NPO policy to prevent cancellations of day of surgery because it wasn't clear to our patients what to eat. They're coming with a full meal. It still happens, but there's more attention given to the process right now. And we're doing carbohydrate loading, Breeze or Ensure you may have seen before. So a little bit about that is important to understand what happens with the carb loading. So in this graph, you see the insulin sensitivity over the post-operative period. And ERAS care patients who have carbohydrate load and all the other elements, their insulin sensitivity variation is smaller compared to patients who are starved for the night before the surgery. Like, let's say they have eaten 9 p.m., their last meal. So they come to have a surgery. When we do big surgery, it lasts about 7-8 hours in addition to that. So it's almost like until they start eating, it's 24 hours pass for these patients before they get any food into their stomach. Some of them can't eat it because they're in pain and they're not waking up until the following morning. So these patients who get into catabolic state, that is shown that insulin sensitivity drops. So they become hyperglycemic as a result of that. And carb loading has shown, like before marathon running, you load up with Gatorades and things, shown to reduce this insulin sensitivity and they have a better glucose regulation. Helps with the complication prevention. I've been asked to sort of touch to liposomal bupivacaine as an alternative for multimodal analgesia. I pulled out this paper. It's a Cochrane review being published just recently, looking at the liposomal bupivacaine versus placebo as salt water, and also standard bupivacaine. The review showed that it is better than the salt water if you inject that to your patients. So it produces better pain sort of outcomes. But it has, none of the publications so far shown that it is better than the bupivacaine, standard bupivacaine. Doesn't mean we don't have enough papers yet. There was 9 papers reviewed in this Cochrane review. Maybe there's more opportunity to explore that area, but it is not showing improvement in the pain scores and length of stay. This was not included in that review. This is more recent from Thomas Jefferson. So they looked at retrospectively single surgeon operations for 532 patients. Again, compared the liposomal bupivacaine to standard bupivacaine, but they couldn't identify any significant reduction post-op narcotic use, adverse events, and length of stay either. So, what is happening with this EPOC? This is today's dashboard. This is how you identify your patients, whether they're in the pathway care. So Rick is doing a couple of spine surgeries today. So his patients there, the elective patients, the inpatient procedures, they're going to be in the pathway care. So in that corner, you see them here. So if you see that, you know what order sets to give. ICUs look at this as well. They think, so they look at it because these patients potential to come to ICU patients as well because they're complex patients. So I talked all about this, just want to touch the data because without that we can't move forward. Key performance indicators collected for this work, and these are the few of those. Order set adherence we are looking for. We're looking at carb loading, glucose management, multimodal analgesia, length of stay as an outcome metric, surgical site infection rates, and readmission rates. So the first graph is the readmission dates in the last 2017 4 quarters and 2 quarters from the 2018. The third quarter is building up yet, so that's why it's 122 patients. But in that last third quarter, we didn't have any readmissions on those patients, but this gets monitored. It's reasonable, I think. We want to do less than 10, of course, but we need to now work to find out what is the commonality of these patients coming back, getting readmitted. So this gives an opportunity to do the PDSA cycle, find these patients, review them further with your help, and identify why they keep coming back, and then develop a strategy to prevent that. Next one is the postoperative order sets. So the one is order set yes, ordered for those appropriate patients, and 0 is not ordered. So from the first column, for example, 175 patients we had in the first quarter, there was 45 orders, the spine surgery orders done, and 130 patients didn't receive that. Louis helped me a lot to, I think, distributed information to residents and fellows to make sure that we are putting the right orders. We send emails regularly, and I guess you get some introduction to EPOC program as you enter your residency training and fellowship training. But this is critical. We need to have a sustainable way of making sure every time residents sort of change, we don't have to miss the opportunity to do the right order set. And then following quarters, we made an improvement after that discussion we had with Louise. And there was a recently, again, I think it was reflecting the change in the residency program. We need to tackle that again. But we are collecting this information every quarter so we know what's happening. This about multimodal analgesia, that our care of multimodal analgesia is Tylenol and gabapentin in the morning of surgery, orally they get. And intraoperatively, if the surgery lasts more than 6 hours, they get IV Tylenol. And they have one more opportunity to get IV Tylenol postoperatively. Otherwise, they go in oral. And then they go into oral Tylenol and gabapentin for 2 days. And they get ketamine intraoperatively and postoperatively. Ketamine, there's a ketamine called ketamine 24, the anesthesia team writes. It doesn't need APS consult. That follows the big spine cases to the floor. But if you think the patient will not be manageable beyond 24 hours because they're complex pain, you still need to get the pain team involved. Otherwise, ketamine 24 is only for 24 hours. It disappears after 24 hours. So you don't need to worry about it. It runs 8 milligrams an hour. It's a very low dose to complement your other analgesics, and it just disappears. You don't need to do dose adjustment or anything. If you see something wrong with the patient, a little confused or having a ketamine gaze, they look at like that, and then just stop it. That's all you need to do. This is our dashboard from 2017. EPOC has a place in the ATE if you want to have a look. 2017 was one of our greatest dashboards, so I just wanted to put that up. And this is the latest one. We're looking at the age caps for pain, communication, care, transition, and recommendation. We are not doing well recently for the EPOC population. We're looking at the 30-day all-cause readmissions, breeze completion, breeze of the carbohydrate, surgical site infections, length of stay. That is improved yet again. ICU length of stay remains steady, so it's less than 2 days. So we did a huge amount of work in ICUs to get these patients discharged early, because they're coming more fitter into the ICU. They're leaving earlier, so there is a great big improvement. One of the contributors to this satisfaction is we are having drug shortages. There's no ketamine left in the hospital. There's no hydromorphone left. It's like, our hands are tied now. I don't know what to do. But we keep taking this back to the pharmacy to give us the drugs we need so we can care for these patients. I think this is partly a reflection of that drug shortages that we are having. With that, I just want to mention the paper that we submitted summarizing our program and looking at our outcomes. Just briefly, I would like to go over this study. So this is from the data that we collect. We have 183 patients that are traditional care group. This is 2012 to 2013 period. And then there's 267 patients in our recent treatment group. And our inclusion criteria for this study was large surgeries, more than 4 levels, revisions, more than 3 levels and above, anterior posterior surgeries, planned stage surgeries, expected blood loss being more than a liter, more than 6 hours, corpectomies, and if the surgeon says this is going to be big, we included them. And a protocol was followed in these patients. So, in our population, our post-op complications didn't show any difference compared to traditional group. And our readmissions rates, again, was not different in the control group and the traditional care group. But our length of stays were different. So our mean length of stay dropped almost 2 days. And now look at the variation in length of stay on this population. It is really significant. Median length of stay again shows significant improvement for total hospital length of stay. Oh, just forget. Case mix index, do you see that number? 5.9. Our heart review average last year was 2.3. So these patients are hugely complex, medically complex. They need huge clinical demand. So despite that, we are achieving that outcomes. And this is over the years how it looks. Our length of stay variation steadily declined from 2012 to 2016 and get tighter. It's nice. ICU length of stay, again, we shaved about a day from ICU stay, and then variation dropped quite considerably. And the post-operative ICU referrals, again, shown to improve in a way that we didn't send as much patients to the ICU because they were in a better state. They didn't need to end up in ICU. Their diabetes was better controlled, their hypertension was better controlled. So that helped to send them to the floor. So this is the money slide. As a result, from 2013 to 2016, the savings generated as an overall saving opportunity was about $4 million as a result of this program. So it caught everybody's attention, of course. So with that, we now expanding this type of program that we did for spine to other service lines, and there's a lot of work going on. But there's more to be done with you together to research this further. So there's opportunity to get into this data. So Rajiv and I sort of start to look at the. Is Dan here? Yeah. Dan is going to take that on board, and then we're going to look at the cost in more detail and how the program performed in terms of more detailed cost analysis. We're going to put that out there. But there's more opportunities to work and improve this care. So I just want to thank these people for their leadership and getting us onto the map. Carlo and Luis did a lot of the work to get this recognized in the system, and every spine surgeon had taken some part to give recommendation, give some advice, and then make sure that things are moving forward. With Christoph, is Christoph here?
No.
So Christoph is also looking at this. We are working together with the ACN work to make sure that this type of work is also reflected to our contractual obligations. So we tell people that we are looking at our outcomes. We are very careful about what we do. And Christoph and Rajiv has been instrumental to translate what we have done here at UW, so the residents get the same sort of information, same standards at UW as here, so there's no variation. When they go there, they face different order sets or different protocols. So that work is in progress because the patient population is slightly different at UW. So we are very cognizant of that. We may do a version of this program for minimally invasive surgeries. That is more frequently done at UW, I understand. Integrated clinics are so important, so we're working with the medicine operative consult clinic, the anesthesia clinic to make sure they have the staff availability so the patient's needs are addressed in a very timely fashion. And a lot of data work goes in the background with IT work to get these order sets done. And again, as you know, as we move to EPIC, you know, our work is slowed down. They're not letting us do anything, but you guys are gonna have representatives to influence the EPIC development for your services. So we will be in touch to include these informations in there.